Good afternoon, everyone. A very warm welcome to all the participants of today's CTD, NITRD, NTF Collaborative Difficult to Treat TB Clinic. It is my pleasure to welcome Dr. Mandal and his team from CTD, all our senior colleagues who are here, Director and Faculty of NTI and NIRT Chennai, State TB officers, Director STDCs, District TB officers, faculty from medical colleges and all other participants, a very warm welcome. I am Dr. Neeta Singla, and on my right is Dr. Rupak Singla, who is head of the Department TB and Chest at NITRT. And on my left is Dr. Amitesh, who is a senior chest specialist in our institute. We are joined by our director, Dr. Divan sir. Dr. Divan, I would request you to give the introductory remarks for today's clinic.
Thank you, Dr. Neeta. Thank you so much. Good afternoon, everybody. I welcome all the people who have joined for this difficult to treat TB clinic. Already 88 people have joined. I am sure normally our difficult to treat TB clinic is getting strength every month. It is becoming more and more people are joining it, and more issues are being discussed and in greater detail. It's a clinic of which we are proud of as an institution that we have been able to make this beginning. And many people are joining who are stakeholders in the control of TB and treating MDR-TB patients. They are stakeholders, senior chest physicians, as well as epidemiologists and program managers who are a part of our clinic. I welcome you all, and I'm sure today's deliberations and proceedings will be as lively and as enriching as they have been on earlier occasions. All the best. Please carry on. Please carry on, Dr. Neeta, for further proceedings. I don't wish to waste the time in this.
Thank you, Dr. Divan. Thank you for encouraging us and doing these clinics. Thank you again. And now today's case is from Mumbai. We have Dr. Shreyas Godbole. Dr. Shreyas, can you say hello? Yeah.
Hello, good afternoon.
Yeah, good afternoon, Dr. Shreyas. He is from Nodal DRTB Center, Mumbai, and he will be presenting the case. Expert for the case is Dr. Alpa. She's also from Mumbai. She's head of the Department Pulmonology in Jupiter Hospital at Thane. And she's also the chairperson for Nodal DRTB Center at TB Hospital, Shibri, Mumbai. She has more than 15 years of experience in managing the DRTB cases. The national expert for the day will be Dr. Rajendra Prasad, sir. Sir, you are with us, maybe?
Yes, I'm here.
Yeah, welcome, sir. So with this, we start today's clinic. I request Dr. Shreyas to present the case.
Hello, good afternoon to all the colleagues and the seniors. First of all, a big thank you for the TB, ECHO and CTD to give me an opportunity to present the case, especially Dr. Divan sir, Dr. Mandal sir, Dr. Rupak Singla sir, and Dr. Alpa Dalal madam. I'm a consulting pulmonologist at Sri Hospital Kalyan and at DRTB Center Kalyan, which is in Peri, Mumbai. So starting with the case, the case is that of a 21-year-old male student, no comorbidities, no any past history of TB or TB contact. He presented to a private nursing home on 20th of January this year with 12 days history of fever on and off, left-sided pleuritic pain, and shortness of breath, MMRC grade 2. There, the chest X-ray of the patient was done, which revealed a left-sided pleural effusion, which was also concurred on the CT scan of the chest. At that location, the patient was hospitalized. The pleural fluid aspiration was done on 2 occasions and 1.5 liters each was removed. The pleural fluid reports were suggestive of lymphocytic exudate with an ADA level of 80, but unfortunately the pleural fluid culture and the gene expert was not done at that point of time. The patient was started on anti-TB medicines with rifampicin 450 mg, ethambutol 800 mg, isoniazid 300 mg, and pyrazinamide of 1500 mg. The point to note is that the patient's weight was at that time 66 kgs. The patient finally presented to a pulmonologist in the private sector on 28th of April 2021, that is after 3 months of starting anti-TB medicines. At this point, the patient had symptoms of persistent fever, loss of appetite, and right-sided chest pain with vomiting. On examination, the patient was having a pulse rate of 116 per minute. His oxygen saturation was 96%, and on RS examination, there was reduced breath sounds on the right side. Subsequently, a CT scan of the chest was performed, which revealed bilateral pleural effusions with right-sided pleural thickening. And on lung window of the CT chest, some miliary nodules could also be found. The patient was now started on anti-TB medicine as per his weight band on 30th of April 2021, which was isoniazid 300 milligram, ethambutol 1100 milligram, pyrazinamide 1600 milligram, and rifampicin of 600 milligram. A repeat pleural tapping was done, this time from the right side, which showed a lymphocytic exudate with an ADA of 35. This pleural fluid gene expert ultra was studied, which showed MTB detected very low, and there was rifampicin resistance detected. The patient was hospitalized again subsequently with symptoms of severe headache, vomiting, mild photophobia, and blurring of vision. This time, an MRI brain plane plus contrast was done, which showed multiple 1 to 3 millimeter sized enhancing lesions suggestive of granulomas in bilateral frontal, parietal, occipital, and cerebellar regions. There was perilesional edema and leptomeningeal enhancement, which can be seen in the subsequent MRI images. His CSF aspiration and analysis was done, which showed an ADA of 5.3, a protein of 56.9, sugar level of 42, and total cells which were 88, which were neutrophil predominant at 70%. A gene expert analysis was done, which showed MTB detected trace, but RIF resistance of indeterminate. Second line anti-TB medicines were initiated on 5th May 2021, which comprised of injectable amikacin 1 gram per day, clofazimine 100 milligram per day, pyrazinamide 1500 milligram per day, ethambutol 1200 milligram per day, linezolid 600 milligram per day, cycloserine 750 milligram per day, moxifloxacin 600 milligram per day, and injectable dexamethasone 4 mg 8 hourly was started, which was tapered over 5 days. And after 15 days, the patient was initiated on oral steroids. A repeat MRI brain was done, which showed no progression of the lesions. The first follow-up of the patient was in OPD after discharge, and that was on 17th of May. At that point, the patient was doing well and tolerated the second-line anti-TB medicines. The dose of the steroid was tapered, and the patient was taken on oral steroids. Unfortunately, the patient had to be re-hospitalized after 2 weeks again on 8th of June 2021 with headache, vomiting, neck stiffness, and rigidity. The patient was restarted on injection dexamethasone. At this point, the patient was referred to the program for starting second-line anti-TB treatment. So at this point, I would like to present a few thoughts as well as a few questions that we had at that point. Should we give the patient bedaquiline, as the CNS penetration of bedaquiline is unknown? Can we add a single drug, that is bedaquiline, to this failing regimen? Should we start bedaquiline upfront or wait for the AFB culture of the pleural fluid and the CSF and do the LPA and the phenotypic DST and then introduce bedaquiline? And last but the most important question, why is the patient not responding despite adequately dosed second-line anti-TB medication?
Thank you. Thank you, Dr. Shreyas. This seems to be a very interesting case. And I will just summarize for the people who have joined us late. So this is a patient which was earlier managed in private sector. It's a young patient without any comorbidities. Yeah, she developed pleural effusion and was given first-line ATT. Patient did not respond and developed CNS lesions while on treatment. And then patient was put on second-line ATT without bedaquiline, but his symptoms kept on increasing despite the treatment. However, patient responded when steroids were introduced. At this stage, patient was referred to the program. Am I right, Dr. Shreyas, in summarizing it?
Yes, madam. Yes, madam.
Thank you, Dr. Shreyas. I would now open this case for discussion to all our DTOs and other faculty who've joined us. If they have any questions from Dr. Shreyas regarding the case. Kindly raise your hands if you have any questions regarding the case history or the case, or any comments that you would like to give regarding this case. Okay, so since I don't see anything,
I think the CSF fluid culture was also done.
Yes, sir. Yes, sir.
My impression was CSF fluid culture was done, and that has shown the INH and rifampicin resistance, and rest of the other drugs were sensitive.
And we are coming to that.
Yeah. No, but that was the case given to us was shown that.
Thank you, sir. There is a question, Dr. Shreyas, on the chat. Can you answer that question regarding LPA?
Dr. Shreyas, there is one question about what was the HIV status of the patient?
The HIV was negative, sir.
Okay. And Dr. Jaikishan wants to ask a question. Sir, Dr. Jaikishan, sir. Sir, you need to unmute yourself. Dr. Jaikishan, sir, we cannot hear you, sir.
Am I audible?
Yes, sir, you're audible now, sir.
Okay. So once second time the patient deteriorated, whether the MRI was done of the brain or not, because despite of the fact that the patient is responding to your treatment, patient may develop the hydrocephalus, and that may be the cause for this the headache and vomiting and the deterioration. So at the second time, the rifampicin aspirin resistance is there, but not to the other, and the patient is already on the MDR treatment. So the question of addition of the bedaquiline at this stage, until or unless we prove the resistance to other drugs, should be there or not, and MRI was done or not.
Dr. Shreyas, could you answer that question? You need to unmute yourself.
Yes. The repeat MRI was done, which did not reveal any hydrocephalus. The lesions were persistent, but there was no increase in size of the lesions.
Thank you, Dr. Shreyas. So now I take this case to our expert for the day, Dr. Alpa. As I told earlier, Dr. Alpa is head of the Department Pulmonology at Mumbai in Jupiter Hospital, and she's also the chairperson of Nodal DRTB Center at Shivri Hospital, Mumbai. Over to you, Dr. Alpa, for your expert comments.
Thank you, Dr. Singla, and thank you for giving this opportunity. And that was very well presented, Dr. Shreyas. So you had asked, Dr. Smita has already summarized the case. So this young boy who is presented initially with pleural effusion and inadequately treated, and later on develops a disseminated TB, including CNS TB, and where we have given adequate AKT and given him steroids too. Now the question that Dr. Shreyas has asked is, should we give him bedaquiline? Because as we all know, the CNS penetration of bedaquiline is uncertain, unknown. Can we add a single drug to this failing regimen? Now, first of all, we have to answer this question, whether will you call this as a failing regimen? Because this patient who is being given adequate AKT, and initially he did show a very good clinical response. When we started tapering the steroids in his case, and that was when he started having symptoms. And when we reintroduced the injectable steroid, he again showed a good clinical response. So we would really not call this as a failing regimen. And we are yet to receive the culture, the pleural fluid as well as the CSF fluid culture we are yet to receive. And before 6 weeks itself, when we started actually tapering the steroid, he started showing deterioration in his symptoms. And also we need to remember in his case that it is not only CNS TB, he has pulmonary in form of miliary TB, and he also has pleural TB. So even if we are not uncertain about bedaquiline penetrating the CNS, because he has disseminated TB and also has pleural as well as pulmonary TB, we would consider bedaquiline because at that side it would definitely work. Okay. And so regarding waiting for bedaquiline, I am of the opinion that we should be starting bedaquiline at this point because there's no point in waiting. We do not know whether CSF culture will show and how long it will take. So it might take about 3-4 more weeks and no point in wasting the time already in the background of him having received inadequate AKT, and there was a delay of about 3 months before we could detect the drug resistant TB. So, so the answer to the question why this patient is not responding despite adequately dosed AKT is, I would say that patient is responding in terms of his clinical improvement. It's just because of this is more like IRIS, immune reconstitution inflammatory syndrome, that is very commonly seen in patients with CNS TB. And as the MRI had shown, this patient did have tuberculoma, a lot of perilesional edema, and multiple tuberculomas, and he also had leptomeningeal enhancement. So he does have a significant inflammatory component. So considering all these points, we decided that it was better to start bedaquiline in this patient. Can you further share the screen? Okay. So we restarted the patient on injection DEXA, and he started showing improvement again. The repeat MRI was done. This is the answer to the question that was asked to Shreyas. And this repeat MRI, which was done on 8th of June, it did not really show any worsening of the brain lesion. There were no new brain lesions, no increase, just about some marginal increase in the perilesional edema. But apart from that, there was no significant change in the lesion. So we added bedaquiline to the regimen on 11th of June. So this was about 25 days from the last AKT chain that was made. We introduced bedaquiline because considering all the points, we thought that this is not really a failing regimen, so it was okay to add bedaquiline. By this time, we got the CSF MTB culture, and culture came positive. So we got the first line LPA done. So rifampicin was resistant, isoniazid was resistant, only CAT-G. Second line LPA showed that FQ and SLID both were sensitive. So that was a good relief to see that it was not FQ resistant. We also got the phenotypic BST done on this culture, and it showed that it was sensitive to Clofa, ethambutol, moxifloxacin, linezolid, and PAS. So these were the drugs sensitive. Okay. So now we have all the information. We have to decide a regimen. So when we form a regimen in this kind of case, which has disseminated disease and significant CNS involvement, we have to consider many factors. We have to consider what is the DST, what is the sensitivity pattern, and what are the drugs that are going to penetrate well into CNS. So now we have a patient who is showing a response, but it's having more of iris-like symptoms. And we have to see that we make an adequate regimen, which is going to prevent further complication and progression of the disease. So as earlier session, Dr. Singla had already taken a session where he had discussed, and is a part of our guidelines. So which are the drugs which show good CNS penetration? So all the fluoroquinolones, linezolid, ethionamide, cycloserine, and carbapenem, they show good CNS penetration. Amikacin and septomycin show good penetration when the inflammation is active, which is so in this case. High dose of isoniazid and pyrazinamide also show good penetration. And we do not have adequate data on CNS penetration of bedaquiline, Clofa, and delaminine. PAS and ethambutol have poor penetration. Now, having considered all this, let us rework on our regimen, whether it is adequate, whether we need to make any changes. So in his case, he was maybe primary MDR TB, so he was never exposed to amikacin, fluoroquinolone, linezolid, Clofa, ethambutol. Ethambutol maybe yes before coming to us, PAS, and ethionamide. So out of these drugs, we know that amikacin, fluoroquinolone, and linezolid have good CNS penetration. Then drugs not used but sensitivity not known, that is bedaquiline and cycloserine. So out of these two drugs which will help us to make our regimen, cycloserine is shown to have good CNS penetration, but bedaquiline is unknown or probably inadequate penetration. Then drugs which are resistant are isoniazid, pyrazinamide, and rifampicin. So we cannot use this drug. So we have at least amikacin, moxifloxacin, linezolid, and cycloserine part of this regimen, which would have adequate CNS penetration. And bedaquiline and clofa is there. It will help for if not CNS TB, part of the other disseminated TB that he has. And ethambutol, fortunately, it is sensitive and supposed to have good penetration in CNS. So now the regimen, final regimen that was formulated or sort of continued, bedaquiline was started, clofazimine weight band had changed now, his weight had increased by 10 kg. So dose of clofazimine was increased to 200 milligrams, moxifloxacin 800 milligrams, linezolid continued with 600 milligram per day, amikacin continued 1 gram IV daily, cycloserine 750 milligram a day, and ethambutol we continued 1600 milligram per day. So even though all other drugs were good enough, but we thought of continuing the ethambutol till the time we were sure how he was improving from CNS point of view. But even after this, patient required 2 more hospitalization for severe headache and photophobia. And every time we were trying to taper off the steroid, symptoms were recurring. Now this patient was referred to the program, and now he was getting the adequate regimen from the program. But he continued to follow up in the private sector because he required specialist opinions. So neurologist opinion was required. So fortunately, myself and Dr. Shreyas, both of us are working in the private sector as well as public sector. So we could probably give him the best of both the sectors and manage this complicated case. And so every time we were trying to taper the steroid or switch over from the injectable steroid to oral steroid, his symptoms would come back. And by now he had also started developing side effects of steroid, water retention, myopathy, weight gain, stry, and all that. And it was a challenge how to manage, ADR of steroid vis-a-vis adequate dose of steroid. So here the question was whether this is worsening or continuation of IRIS. So adequate dose of AKT was assured, optimum selection of drugs was assured, and according to the DST and CNS penetration, he did not have recurrence of fever, which he had presented the first time in April. He did not have any recurrence of fever. He continued to have good appetite and cough was not there. And every single time he was showing good response to increasing the dose of steroids. So with that, we concluded that is probably more of IRIS rather than disease progression, which is causing the symptom. So the challenges that we faced in this case was determining IRIS versus disease worsening. In the private sector, and the challenge is that patient has to pay for all the investigation, repeated MRI, repeated hospitalization. Patient was really not that affording. So we had to take a lot of clinical decision at times. Another challenge is these patients, when you are giving the multiple drugs with the steroids, adverse drug reaction monitoring is, it has to be very vigilant. Monitoring the response to the treatment, because this patient not only has CNS TB, he has disseminated TB. So how do you monitor the response? Every time getting a sample because it's not producing sputum. So we have to do multiple imaging in this patient to ascertain that he is responding not only from CNS, but also pulmonary and pleural diseases responding. Monitoring the treatment response, that we have to follow him up, clinical, radiological, and microbiological in this case is not possible. And managing and monitoring the steroid related ADR. So all these challenges had to be managed, and I was happy to share that me and Shreyas both together with the support from the program or getting adequate regimen, we could manage most of the challenges. And so what we decided, this is our experience with the neurology team at Jupiter Hospital, that many of these patients who get iris and oral steroid penetration is sometimes not adequate. So we continue to give them injectable steroid for long term. And almost about 15-20 patients we manage this way, where we continue to give them injectable steroid for a longer duration on OPD basis and then switch over to oral, which is what we tried in this case, and it helped. And we have tried thalidomide for few patients, giving the dose of 100 milligram BID. It has a good immunomodulative effect and a steroid sparing effect. There aren't very good robust studies in this, but there are some case series, especially in pediatric population, where they have used thalidomide as a steroid sparing agent. And we've used in about 4 or 5 cases and found good results. So he was started on thalidomide. And then we decided to taper off steroids very slowly, which is what being done now. And presently he is on dexamethasone 2 milligram per day, thalidomide 100 milligram twice a day. And we monitored him for ADR. So he didn't have any symptom, but routine audiometry evaluation was being done monthly. And after 3 months of treatment, was detected to have mild sensory neural hearing loss at higher frequency. So this is when we stopped amikacin. And next slide. So what's the present status of this patient? He had just come for follow-up about a week back. He's completed 5 months of anti-TB treatment. He has no CNS symptoms now. He's gained about 20 kg, and part of it is not just the improvement, but also because of steroids. Repeat CT scan chest has shown good resolution. The miliary shadows have reduced, and even the pleural effusions have gone. There is good clinical and radiological response, CNS and extraneural sites. Thalidomide and dexa is on, and steroid-induced ADR. He does have myopathy, Cushingoid features, stride, fluid retention, but he's quite motivated young chap, and he's doing his physical activity, exercises, and daily exercise routine, and been able to do all his activities independently. So this is the present status. This is the latest CT scan. You can appreciate here the effusions, both the sides have reduced, and the miliary shadows have also reduced. So, okay. So here we are continuing to monitor him in terms of the response, steroid-induced side effects and AKT-induced ADRs, and the bilateral lower limb nerve conduction studies were done because he used to complain of some tingling. Fortunately, he does not have any neuropathy, and he was complaining of some leg pain related to myopathy. We got his both the hip joint X-ray because avascular necrosis is pretty common in these young chaps who receive steroids. Audiometry reveals this sensory neural deficit, and 3 monthly optal evaluation is being done to detect, because he's on linezolid and ethambutol both. So this is how, with the help of support from the program and the private sector and the specialist help, we're able to manage this case. And so the take-home message for this case is that initially this patient did receive inadequate AKT dosages. So inadequate AKT dosages and inadequate investigation, you can miss the presence of primary drug resistance, or you can create a drug resistance. And I think we have to send this message across to our physician colleagues or to other colleagues who are in the private sector. So that kind of awareness needs to be created, because this young chap, if it was detected in time, he did not have gone through all the misery and trouble. High index of suspicion for CNS TB and appropriate imaging studies is extremely important. So many times this patient present with vomiting as the initial symptoms, and that can be diagnosed as gastritis or AKT-induced ADR, and the diagnosis of CNS TB can be missed. Another important insight that we got in this patient, that sampling from different sites is very important. Now, in his case, it was very easy to do pleural fluid sampling, and we got the diagnosis with GeneXpert showing resistance. But subsequently, we also went ahead and do CSF sampling. And then we found that pleural fluid did not grow AFB at the end of 6 weeks, and CSF grew culture. So where we could do the genotypic and phenotypic DST. So it's extremely important in these patients. You should do sampling from different sites because sometimes we get different results also. And public-private partnership and specialist opinion is extremely important in managing such challenging extrapulmonary TB cases. And that's what I think in program also we need to probably develop and have specialists available thing where patients who cannot afford the treatment in the private, we must develop such centers where we have all the specialist help available. And private sector should, this is also an important message to the private sector. Now myself and Shreyas both having worked in private as well public sector, we are aware and how to refer the patients and give best chance to a patient by giving best regimen. But many doctors in the private sector do not know this and they continue to treat the patient with inferior regimen rather than referring the patient to the private sector. And that also a very right message has to go across. And not all CNS symptoms are due to treatment failure. As we see in this, iris is pretty common in CNS tuberculosis. So whenever you have symptoms, you should not label it as treatment failure and make adequate attempt to treat them with adequate dosage of steroids. ADR monitoring, imaging, proper investigation, specialty care, and teamwork is extremely important in management of difficult to treat TB cases like this, especially extrapulmonary tuberculosis cases. Thank you so much for giving this opportunity, and be happy to have comments from the national experts.
Thank you, Dr. Shreyas and Dr. Alpa. It was indeed a very, very nice case, and I think it's a perfect example of a case which, when presented in the field, we should be able to recognize when to send this patient to a higher center. And then again, it's a very good example of the teamwork where the whole team has come together and managed such a complicated case so well. And also a case for public-private example where such a good coordination has happened between the both sectors and the patient is managed so well. And it's great to see that patient is responding so well to the treatment. So congratulations to the team, and thank you, Dr. Alpa. Now I'll invite Dr. Rajendra Prasad sir for his comments. But before that, if there are any questions from the audience, we have Dr. Jayakishan. Sir, you want to ask a question?
So there is one thing that the pleural vein is having the passive bacillary type of the TB, and many a time on say the CBNet or the gene expert, many of the cases are not picked up. Okay, so should we make it a policy decision that in case of the pleural vein, instead of depending upon the composite criteria for the diagnosis for the TB and for the CBNet, we should be doing the culture of the pleural fluid to have the early identification of the drug resistance?
Dr. Singla, would you like to answer the question?
Yes. Thank you, Dr. Jayakishan, for this, I think, very important question. In case we have a case of pleural fusion, then besides doing the cytology and the biochemistry, what else should be done? You see, as far as the program goes, because the low sensitivity, which is around to the tune of 50% or so, in routine, the program has not approved pleural fluid to be sent in every case for the genotypic test like CBNet. And but yes, in a case where you find the response to the treatment is not as expected, it is getting delayed. There are other organs also being involved. So in these cases, definitely it should be subjected to the genotypic test also.
So should we make it?
Yes. Yeah. Please let me continue. Yeah. Then we'll take. And also, there is no question that it should be sent for culture and DST. Whenever the pleural fluid is tapped, it should always be sent for the culture and DST also. Because in case you find culture is positive, again, the genotypic test can be done on the culture as well as the extended DST can be done on that also. So this message should be clear that not only cytology and biochemistry, but we should also culture these fluids. And in some specific circumstances, as of today, as per the current guideline, we may subject it to the genotypic test, including the CBD. Yes, sir, you were saying something.
Thank you, sir. Thank you.
Thank you.
Are there any other questions, Dr. Amitesh?
Yes, ma'am. Dr. Alpha, there is one question in the chat box by Dr. Anand More. He had a similar case of drug resistant disseminated TB with CNS TB having chromatomas. And the physician there has advised him to extend bedaquiline beyond 6 months. So what are your views? Can it be done? Or what are the recommendations by the program? Please guide.
Yeah, okay. So voice was not very clear. Where is this? I will just read the question on this. Question is by?
It is in the chat box, ma'am.
Okay, I'll see and I'll answer. Meanwhile, the discussion
Yes.
can go on.
So are there any other questions? Dr. Alpha is going to answer that question. Please raise your hands if you have any questions. Dr. Anand, you are there, so maybe you can ask your question. You need to unmute your, yes.
Unmute Dr. Anand. Dr. Anand, you need to unmute.
So then tuberculosis patient having that operated tuberculosis patient, the neurophysician and chest physician advised two tablets BD that I have given the just chat now. That 2 tablets BD, that bedaquiline is finished within 1 month. That is 4 tablets BD or DD. So what should we do that further bedaquiline to provide?
Okay, thank you, Dr. Anand. So, Dr. Singla, the question is whether can we increase the duration of bedaquiline if it is what I could understand from this question was, is there a scope of increasing the duration of bedaquiline?
Yes, you see, there are two parts.
So that data having that 8
One
days
is
brain.
the bedaquiline in the initial 2 weeks, we give it daily and in higher dosages. And after that, we make it intermittent, twice a week, and reduce dosages. So as of now, there is no recommendation to increase this 2 weeks period wherein we can give higher dosages. Yes, after 6 months, the new drugs like bedaquiline, they can be extended as per the current national guidelines in 2021, is that in case you do not have more than 2 drugs in the subsequent phase after 6 months, because of the lack of other drugs efficacy in the from group B or from group A or C, in that case, the extension of bedaquiline can be considered. So that is the guideline. In case you feel that in case you stop bedaquiline, you will not have more than 2 drugs from group A, B or C. In that case, one can extend the bedaquiline.
That is after 6 months, sir.
Sorry? After 6 months. Yes.
After 6 months.
After 6 months.
Now what should do? That is that bedaquiline finished within 1 month. Remaining 5 months.
Recording in progress.
No, your question is not clear. Before 6 months, are you saying to extend, or in the first 2 weeks you are indicating to extend?
Dr. Anand, we are not able to hear you clearly, so we are not able to take your question. Maybe you can write it on the chat again and we'll take
Given the chat, madam. Chat given. I have given the chat. I have sent chat.
Okay, okay, sir. Dr. Rishi, you have a question?
Sir, just we want to know, because in DSTB, we give the duration up to say 9 months, sir. But in CNS DRTB, first of all, it's quite difficult to diagnose, but here the case has been very clearly diagnosed, and by the CSF sample also we can take the sample for FLA, SLA, and culture also. And on the basis of that, we can diagnose a CNS DRTB. But sir, my concern is the duration of the DRTB in case of CNS MDRTB. This is not clear to me, sir. Please guide, sir. So is it same as the that of a pulmonary DRTB, or it is the duration same as we have in pulmonary DRTB, or it is something different, sir? This is my concern, sir.
Yes, Dr. Rishi, thank you for your question. You see, in case of CNS DRTB, in case we have chosen to give odd or a longer regimen, that must be done because the shorter regimen in CNS TB is out. CNS DRTB, it is one of the contraindication, CNS DRTB for the shorter regimen. So the next choice is the odd or a longer regimen. So in that case, 18 months to 20 months period as currently suggested for the DRTB, it should be enough. Only in very extreme circumstances, when you find that no patient is not responding despite 18 to 20 months, that should be very rare situation. Otherwise, 18 months to 20 months should be enough for treating CNS DRT.
Thank you, Dr. Singla. Are there any questions
Yes,
on the chat?
there is one more question, Dr. Alpa. Are you there, ma'am? Are you there, ma'am, Dr.
Yeah,
Alpa?
Dr.
Yes.
Alpa.
Okay, there is one question that moxifloxacin was used in the final regimen. Is there any specific reason for that? That why was it preferred over levofloxacin?
Yes, so initially when we had initiated, that time we had only the information about the gene expert on pleural fluid, which showed REFA resistance, and we did not have the LPA report. So we did not know whether this patient has FQ resistance, subsequently would have, and that's the reason why moxifloxacin was started. And we did not change it again once we had the LPA report.
Okay, ma'am. Okay, thanks.
So are there any other questions? Okay, then I invite Dr. Rajendra Prasad sir for his expert comments.
At the very outset, I must thank Dr. Nitya and Dr. Rupak for really inviting me as a national expert. I see in the audience, many of my students are sitting. And I must compliment in the beginning both Dr. Shreyas and Dr. Alpa Dalal for a very, very interesting presentation. And what I believe as a clinician, the things which ends well is always a good. So in this case, one thing is very clear, that patient ultimately has responded whatever treatment was given, and treatment was given to my understanding as per any of the guideline. So still I have some points to share. If I may be allowed to share my slides. Nita, can I share
Yes,
my
sir.
slides?
Yes, sir. Yes, sir. You can.
So my slides are visible, I believe.
Yes, sir. We can see them.
Okay. So as you all know, at this stage of presentation, that this was a young male and had symptom for 12 days, suggestive mainly of pleural involvement. And ATT was initiated, as you know, he was 66 kg, and everybody will agree that dose was inadequate as in terms of rifampicin and ethambutol, especially in terms of ethambutol and rifampicin and ethambutol. Even pyrazinamide was less for 66 kg. So what I'm trying to say that, why it is not moving?
So वो enable editing करना होगा, then it
अच्छा, enable editing. Okay, thank you. Enable editing. Thank you, Nita, for the rescue. So I was discussing about the dose. So what I was trying to say that is this was definitely not an appropriate dose, and that speaks very clearly, which I'm speaking for last more than 4 decades, that we need a good education in tuberculosis. That why into 2021 people are prescribing inadequate doses for anti-TB drug, especially the primary line, because that may create a lot of issue. So that is my one point, and that's why I have written in the red that more and more, I think Dr. Mandal is here, Dr. Diwan is here, Dr. Rupak is here, all the stakeholders, many of the stakeholders are here. So we should educate especially the private sector one, to educate them, because at the end of 50 years, if this is the state of affair, this is not good. So as you see in this case, after 3 months of intake of inadequate doses, he was sent to a pulmonologist in the private sector. And ideally, if somebody has thought in the beginning, the genotypic of pleural fluid, which is very easy. I see in the private sector, everybody is doing the genotypic test of the fluid. So if that stage, it would have been done, it have thrown some more light, whether it was a primary drug resistance or acquired drug resistance. My think at this point was, why there was no response. It may be because of the underdosing. Patient, I don't know whether he was really adherent, because that is another issue which has to be addressed very clearly. And was a primary drug resistance, probably initial molecular test of a fluid, which is very common now, especially in a city like Mumbai. So that could have been done, that have been probably solved the question. And at this stage, hardly any this iris is not in the mind at this stage. And to my understanding, if CT would have been done in the beginning, the doctor would have known that this is not a simple pleural effusion. This was a disseminated tuberculosis in terms of fluid, in terms of miliary shadows, and then ultimately the MRI of brain was done. So it was a disseminated tuberculosis, and in pleural effusion, it was a moderate pleural effusion, and it was a bilateral pleural effusion. Is still evidence, although don't talk for starting of steroids, but then steroids should have been started in the beginning, especially taking care of bilateral effusion, moderate effusion, and miliary shadows if CT would have been done in the beginning. And of course, the dose was modified ultimately. And after 1 month of the following that treatment, he developed new symptoms in terms of headache, vomiting, photophobia, and blurring of it. That at this stage, actually, it was that whether it was a drug resistance, primary acquired because of inadequate doses, or is it a iris component of the iris? And iris is not new. It's with the advent of HIV, it was more known, but it was known before also. People used to have these paradoxical rates. So that was not very clear in the beginning. And then this Gene Expert Ultra was done, that has shown, very low type of detection, and even the test might have been repeated at this stage to very clearly say that whether it was a drug resistance or it was not a drug resistance. Ideally, the culture would answer these questions very effectively. And then second line, finally, second line ATT was started, and ideally in the beginning, when second line drug was started, ideally all oral longer regimens should have been started, keeping everything in mind that he had bilateral effusion, he had miliary shadows, and then he has a brain granuloma. So keeping all these, ideally the bedaquiline was started late when he was referred to the public sector. So that speaks very clearly there should be good coordination between private and public sector. And I was told that the neurophysician and the neurosurgeon should have been consulted, and because in such type of cases, we pulmonologists cannot be a very clear guide for such type of cases. So that particular specialty should be involved in taking the opinion, as Dr. Jai Kishan was talking about the hydrocephalus, although it was not there, but to have a more idea, specialist, super specialist. And now question is that patient has responded. Ultimately, bedaquiline was added. Now one question was raised: how many months of bedaquiline? Ideally 6 months. There is no guide to extend the bedaquiline in such situation. But yes, we may think depending upon, but patient has improved. So there was no question of extending the bedaquiline in this case. And good thing that thalidomide was added, although evidence is very weak and some of the case reports are available. It acts as an immunomodulator, but it has ultimately, I think, acted very well. And in this case, patient has responded, and whenever he had, one more point comes to my mind, when he had frequent, in between he had headaches, and that is why the steroids has to be given repeatedly. In such situation, my feeling after treating such type of cases for very long years with the help of neurologists and neurosurgeons, the dose of steroids might have been little prolonged, well injectable as well as oral. In this situation, what we see that because it appears now that it was due to it appears in this case as patient has gained 20 kg of weight, although it is part due to the steroids, but patient has improved. CT picture is clear, CT head is clear. So everything, there is no doubt that patient has improved. And treatment, what should be the duration of treatment? I believe somebody has raised this question. My understanding is usual 16 to 18 months or whatever usual duration of bedaquiline containing regimens. All longer oral regimens are there, that he should be continued, and he should be regularly kept on a follow-up after the treatment is stopped. That is one more thing. As somebody has raised question in a drug-sensitive tuberculosis, in such disseminated tuberculosis, we increase the duration of the treatment of drug-sensitive TB for another 3 to 6 months, another 3 to 6 months, what neurologists say also. And so here we have to be always keep under him follow-up, very regular follow-up, and to see that whether he needs some prolongation of treatment or not. But at this stage, this is a very hypothetical question. So I think with these few words, I once again, and another reason I believe of frequent headache could be the drugs. And especially when you are using cycloserine, we have seen such type of symptoms sometimes in patients who are using. So those things must be kept in mind. Although Iris is now looks very clear option in this case. That is why he is responding every time to these steroids. So I think with these slides, I once again thank both Alpa and Shreyas for presenting a very interesting, a very informative case. And I thank Rupak and Nita Singla for giving me this opportunity. Thank you very much.
Thank you, sir. Thank you so much for drawing our attention to the very basics of managing the case right in the beginning. And that is where we, all people who are in the field, we need to be very careful about. Thank you again, sir. Dr. Singla, I would request you to summarize the case so that we can close the case.
Yes, thank you. You see, first of all, I must thank Dr. Shreyas and Dr. Alpa for choosing this case, presenting it so well and discussing it so well. And of course, Dr. Edha Prasad, with his vast experience, has also picked up certain points which we should keep in mind. Now, in case we want to say the take-home messages from all this discussion, Number one, as it has been repeatedly emphasized, is must give correct dosage as per the guideline. In case the dosages are incorrect or they are not taken regularly, then the response to treatment may not be good, and sometimes it leads to development of failure to treatment and resistance to treatment. And also about the extrapulmonary TB, you see very often we see in most of the places the pleural fluid is sent only for the pathology and the biochemistry and things like AD, etc. But people forget about sending it for the cultures. It must be sent. And in some specific circumstances, as of today, because the program, they want to conserve their resources, and they are not recommending routinely to be sent for the genotypic test, but in special circumstances when they have multiple organ involved and patient is not showing adequate response, then even the genotypic test like CMINET should also be done. And then there was a question regarding the should we add bedaquiline to the failing regimen, or you see we need to be very clear that when to call a regimen as failing and when to call as a modification of the regimen. Like in this case, it was too early to call it a failing regimen. It was just 3 months of this. So in that case, in case we have started a regimen and we find that we could not give a particular drug and now it can be considered. So this is called modification of the regimen, which is permitted. So here we do not say no or don't add one drug or two drugs. If the regimen is being modified, then this can be done. But after 6 months or so of a particular regimen, and then you try to add one drug, that is not correct. That would be adding a drug to a failing regimen. So these two things need to be differentiated. And as doctor explained very beautifully about the immune reconstitution inflammatory syndrome, this occurs most commonly with the lymph nodes, which increase in size in the beginning and then they may reduce. And again, on treatment, they increase in size. The same thing has happened in this case in the CNS TB. So it sometimes becomes very difficult to say whether this patient is heading towards failure of the regimen or towards the iris. But in this case, the pointer was that on the withdrawal of the steroid, patient was deteriorating, and when the steroids were reintroduced, patient was responding. So that was a good pointer which was picked up by the treating team. And also, you see, we should also keep in mind sometimes the low blood levels. Whenever you find after 3-4 months the patient is not improving well, ensure the compliance. If the compliance is good, then at the back of mind, besides thinking of failure of the iris, even the low blood level should also be kept in mind. That could be one of the reasons. Also important from this case, which we take home is regarding, we always have fear in mind whether these regarding the CNS penetration of bedaquiline, delambrate, and clofazimine. We know which drugs are good, which drugs penetrate well, and which are like PAS and ethambutol are not good drugs to penetrate the CNS well. But regarding these good drugs like bedaquiline, delambrate, and clofazimine, as of now the data is sparse. Mostly we have animal studies which have shown, very few clinical studies. But in the case of CNS TB, because it's a question of life and death, we know in case we do not make a proper regimen, I think as of today, we should consider these drugs also to make a regimen in the interest of the patient, so that we can make the regimen robust and accompanied by the other drugs which are known to have a good CNS penetration. So these are some of the key points which I would like to mention to everyone to take home. Otherwise, I must say again that very well presented and very well discussed by Dr. Alpha, Dr. Yas, and Dr. Indra Prasad comments. Of course, they were very nice and informative. Thank you.
Thank you, Dr. Singla. It was indeed a very good case and a very, we all learned a lot from this case. Now I request Dr. Ashok Bharadwaj, who is the chairman NTF, who has joined us, and Dr. Divan sir. Just for information, we were joined by 17 states today, and other 7 STO sirs have joined us, and 5 STDCs have joined us. So I would request more for Dr. Ashok Bharadwaj sir. We would like more and more states to join us the next time. And the STOs who have joined us are from UP, Rajasthan, Meghalaya, Mizoram, Sikkim, Jharkhand, and Chhattisgarh. The STDCs who have joined us are from UP, Rajasthan, Jammu and Kashmir, Jharkhand, and Chhattisgarh. So thank you everybody for joining us, and over to Dr. Ashok Bharadwaj sir for his closing remarks.
So thank you, Nita. Thank you, Dr. Rupak. So the thin attendance, I can explain that the joint sportive supervision mission is continuing in the country, and most of the experts, they are engaged in that. So I was also in Jalandhar. I was also in Jalandhar. So I joined at 12:30 when I got the connection. So Nita, I want to say two things. One is I interacted with private practitioner in this city, and the sorry state of affair is the patient is referred from public health, public sector. The patient goes to the chemist, patient take medicine for 7 days and do not turn till 15 days. This is one. And then we visited private practitioner and he is getting about 40-50 patients per month. But says that, hello, I'm audible?
Yes, sir, you are audible, sir.
The patient take medicine for 1 month from private itself for 4 months because the course of the medicine. So we have to strengthen this public-private system so that the patient do not suffer at all. Patient do not have out-of-the-pocket expenditure. The patient do not have catastrophic expenditure. We interacted many patients. There were many the interesting cases which we are missing. So patients are sometimes spending about 70,000-80,000 rupees from their pocket. So this is a very sorry state of affairs. So one comment, because I'm not a TB expert, I am just a public health person. So we must use the newer drugs judiciously. The situation should not come that we get the report that the patient, they are turning resistant to bedaquiline. So thank you, Nita, thank you, Rupak, thank you, Dr. Dalal, for excellent case presentation. And we must come forward for these cases. Thin attendance is due to the festival season and due to the joint sportive supervision mission being carried out in the country. The DDG sir is in Andaman. I was in Punjab. So thank you, Nita, for doing wonderful job. Thank you, Dr. Rupak. So carry this forward, and we will have interesting cases in future also. So thank you very much.
Thank you, sir. Thank you, Dr. Diwan sir, Dr. Rajendra Prasad sir, Dr. Alpa, Dr. Shreyas, Dr. Singla, and Dr. Amitesh for supporting this clinic. And with your guidance and your support, we are able to run these clinics. I would also like to thank all the state TB officers who have joined us, faculty from NTI Bangalore and NIRT Chennai, the state TB officers, STDC directors, and the faculty from the STDCs, faculty from medical colleges, district TB officers. Thank you, everyone. And as I can see in the chat, Bihar has also joined us. So thank you for joining us. Thanks a lot. Thank you. Kindly give your feedback on the poll that is floated on your screen. That will help us to improve further.